It's 4 p.m. Italian time, so it's time for Food for Veins and Veins for Food. As always, we welcome 30 seconds for allowing everybody to join the platform. So 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, and welcome everybody again to Food for Veins, Veins for Food, a not-for-profit humanitarian and educational initiative that always starts with the art and heart of Monica Glowinski, dedicated to all the health professionals who have shown heart in this tough COVID time, because indeed, as requested by Lancet in a recent publication, this educational initiative is also in support of the post-COVID economic crisis. Nothing would have been possible without the stellar support of a stellar faculty and also of the many who all around the world are joining us in this teamwork, and that we deeply thank, as we deeply thank the previous webinar keynote speakers also for having answered to all the questions in whatever language we received during the previous webinar. So I encourage everyone to make the questions in the dedicated question and answer box in whatever language, and we will reply, if not live today, in the following days. Today we focus on a very important topic, endovenous superficial procedures. Also today we will give international CME credits. And also today we will enjoy truly stellar keynote speakers in the person of Professor Kinnani and Professor Urbanek, who will be introduced properly later on, as we will do with also Professor Kabnik and Professor Chi, who we deeply thank for having taken part in the recorded video lessons that are additional educational material you can find inside the VWIN Foundation page. As I like to deeply thank once again Professor Kabnik, but also Professor Catherine Gibson and Professor Angelo Scuderi for serving today as honorary chairs, which means that they will wrap up the main take-home messages we should all take home with us, but not before having enjoyed the important comments coming from all around the world from our continental experts, representatives who will introduce properly later on as well. Nothing, as I said, would have been possible without a phenomenal teamwork of professionals, health professionals, donors, and what we define also the Magnificent Seven, so the companies who took part in the initiative. So we deeply thank once again Amnol, Balton, Bayer, Medi, Servier, Sigvaris, and Tactile. So deeply thank to all of you. It's our deep hope that we will not just keep on talking about food just for humanitarian purposes, but also for a dinner all together as soon as possible. And today it would have been beautiful to do that also with a birthday cake in honor of our dear friends and esteemed colleague, Professor Shoaib Padaria from India, because today indeed it is his birthday. As always, at this point, I pass the mic to the esteemed colleague and friends that I call also family. So Oscar, the mic is to you.
Thank you, Sergio. Thank you to each and every one of you for your participation in this important event once again. And also thank you for supporting this humanitarian campaign to fight hunger during this pandemic. Pueden hacer las preguntas en español todos aquellos de habla hispana. Gracias a todos por participar en este importante evento una vez más. And I want to mention that Latin American will be able to make a question in Spanish. Let's start this expert meeting. Thank you.
Gracias, Oscar. Willy?
Dear friends and colleagues from wherever you are, good morning, good afternoon, and good evening. And let's start.
Thank you so much, Willy, for being always so effective. So I will share my screen once again, because as per tradition of this webinar, we always welcome a guest of honor in the person of a top health professionals related in some sort of way to venous and lymphatics. And today we decided to make an exception, having as guest of honor not a health professional, rather a non-health professional. Because indeed the public venous and lymphatic awareness is made possible also thanks to the public. And what a better example than Anna Maisetti, a wonderful person, author of a textbook named Lymphedema After Cancer. But a wonderful communicator. You see over here also some examples of her reproducing paintings related to compression items from the past, like this one from the previous century, promoting proper lifestyle for patients in need of venous and lymphatic support. So I will share over here with you her video. So allow me to share it once again from here, because we have to include also her audio.
Dear vein and lymphatic specialists from all around the world, begging the guest of honor of today's webinar is indeed my deep honor and pleasure, particularly because I have the honor of representing all the population to whom are addressing your professionalism. For the public and evidence-based information is fundamental, particularly in this time in which medical fake news are so frequent. With great interest, I will enjoy this webinar dedicated to venous treatment, particularly consider it that venous treatment can potentially influence also the lymphatic function, two faces of the same medal, like health professional and the public are two faces of the same medal indeed. So I congratulate and thank all of you for initiatives like Food for Veins, worthy of a gold medal for the both educational and humanitarian perspective, brought to both health professionals and patients. A virtual toast, then Food for Venice and Venice for Food. Thank you.
So from this, we move from the non-health to health professional, and it could be no more professional than this, because introducing Professor Khilnani is like introducing Michelangelo, of course. So he needs basically no intro. I will just, as always, sum up in 3 points. We know he is one of the heads of Cornell University, is the immediate past president of the American Venous and Lymphatic Society, and he is the reason why I use the term nilometer as a unit of measure for niceness, because whoever knows him knows that he is a wonderful person, really nice also outside the professional arena. The reason why I wanted to have Anna Maisetti with us, who is involved with the lymphatics, is because what we do on the veins, of course, influence also the lymphatic part, and we will dive into the topic of veins in one of the hot topics. And hot is the real term, because Neil will talk to us about thermal tumescent. And with this, I pass the mic to Neil. Neil, you can now share your screen, and we will all enjoy your keynote talk.
Thank you very much. I'm assuming you can hear me and see my screen.
Yes, perfectly. So the mic is to you now.
All right, thank you. Hello, friends around the world. And, thanks for supporting this really wonderful cause. And there I am. And I just wanted to point out that I have no disclosures for this talk on thermal ablation. Dr. Elias summarized the various options that we have these days in terms of ablation nicely with these technical terms. And I'm going to focus my attention particularly on thermal tumescent, radiofrequency, and laser. Dr. Elias, in a more recent Endovascular Today article, summarized his thoughts as to how to make decisions with regard to ablation techniques. And I'm just going to hide my video panel. And I wanted to drill down a little bit into what the data is that supports some of. Can you hear me?
Yes, we can. Go.
Oh, okay, good. Sorry. I'm going to drill down a little bit into two of the recommendations that he makes. One, that when you get to very large veins, 12 millimeters and larger, that thermal tumescent is the choice. And then the other recommendation is that when you're treating the below knee, or particularly the low calf, great saphenous vein and small saphenous vein, that you should avoid thermal ablation. So though my presentation goals today will look at what the prevalence of large diameter great saphenous veins are, and how successful is thermal ablation there. And secondarily, for the lower calf, how often is GSV and SSV, or how often is ablation of those necessary, and how morbid is thermal ablation in the low calf? So looking at some of the data from some of the trials that have reported outcomes after ablation, we can extract some epidemiology for how often larger veins exist. And in this study from Pittsburgh in 2011, 12% of the veins were greater than 10 millimeters in diameter, measuring at the proximal great saphenous vein. And those were mostly great saphenous veins, not very few small and anteraccessories. In this study from Mark Whiteley, looking at outcomes after treatment, which we'll talk about a little bit later, he measured or estimated 17% of the veins in his population were greater than 15. And if you look at the curve, I would sort of extrapolate that to about 25% of the veins he treated were bigger than 12. And then from the French Society of Phlebology, written by Dr. Hamel Desnos, there was a review of the size of the saphenous vein in a population of patients that are fairly representative of what we see. What they used were mid-thigh diameters, a little different than the proximal great saphenous vein diameter, and they found that about 9 to 10% of patients had a great saphenous vein larger than 8. But if you use Dr. Mendoza's conversion factor for proximal thigh to saphenofemoral junction sizes, that corresponds to about 14.2%. So maybe we're talking about somewhere in that range for what's 12 millimeters and larger, maybe even a little bit more than that. In terms of clinical data for outcomes of ablation, there was this study written in 2015, published in Journal of Vascular and Interventional Radiology, chronicling 49 veins that were treated that were greater than 15 millimeters, measuring up to 26, with 5 of them being greater than 20 millimeters. Fairly standard parameters for great saphenous vein ablation with laser, only they used more energy than you're probably used to using, which I think is important to note with big veins. And then their outcome was reported as typical up to 12 months. 48 of the 49 veins closed at 1 month. They retreated 1 and it closed at 12 months. They were all closed. Good clinical outcomes, no DVT, no paresthesia. They did note that multiple accesses were required in 14% of these patients because big veins tend to be more tortuous. And they had to treat 6 patients with 2 access points and 1 patient with 3 access points. Another study looking at laser, again, fairly typical parameters here. 30 patients were treated with 90 joules per centimeter and another 34 with a personalized prescription that's very similar to what was in the JBI article I just reviewed. They used Lovenox after, or enoxaparin afterwards. 90% of the veins were closed at 1 year if they used 90 joules per centimeter, but when they upped the dose and dosed it to the size of the vein, they closed 100% and they had no thrombotic complications. And then getting back to the Pittsburgh study, with the veins that were bigger than 10 millimeters in diameter, they showed equivalent outcomes in the veins larger and smaller than 10 millimeters. They needed a little bit more, or they used more energy in the larger veins, which is probably worth noting. One last laser review is a very large study from Dr. Whiteley, 334 veins bigger than 15 millimeters. Typical standard approach, except one thing that he did, which was a little different, is he used a multi-pass technique. So when the vein collapsed, often the vein creates a sort of smile sign. He would introduce the laser fiber here, treat, and then pull back pull back typically, and then reintroduce the laser fiber, and then move the laser fiber to another part of the vein and pull back again. And Dennis Borsuk, one of the discussants, does that as well. And he had at 8 week shorter follow-up, 100% closure with no thrombotic complications. Not to forget radiofrequency. Dr. Calcagno is really the only study I could see on this. Treated veins both larger and smaller than 12 millimeters and had equivalent success and complications. He had some small saphenous veins mixed in there, but of note, 28% of the veins in the study were greater than 12 millimeters in diameter. How often is below knee great saphenous vein and SSV ablation needed based on epidemiology? Here's a study from the Imperial College, excluding patients with prior treatment, prior thrombosis, and congenital anomalies. Here's the flow chart for the exclusion. And ultimately, 30% of the patients they examined were in the cohort that were going to be reported. If you look at this diagram, it summarizes the data. 42% of the patients had reflux from the junction down into the low calf. And another 230 had reflux in the thigh, excluding the junction, and down into the low calf. So that adds up to about 55% with what we would consider significant great saphenous vein reflux in the lower calf. But there were a number of segmental ablations as well that would add up to make this total population 80%, but it's hard from that article to tell how severe the Bologna reflux was. Dr. Pitaluga's numbers were a bit lower. 14% of the veins that were in his study looking at reflux had Bologna great saphenous vein reflux, but recognize some of these veins did not have reflux at all. They just had branch reflux. And so if you looked at just those with reflux in all the veins, just those veins with reflux, this number would be higher. And then more recently, a large study of consecutive patients studied with ultrasound from Brazil with C2 patients that were C2 patients. 11 to 12% of the patients had great saphenous vein extension from the thigh into the calf, with a variety of additional segmental refluxes in the calf, which may or may not be relevant. So that looks to be 11 to 17% of the scanned patients, 40 to 60% of those patients who had reflux who were women, and very similar numbers for those who were men. And then finally, I'm going to talk a little bit about this study later from Dr. Thiva Kumar. But in his study where he ablated Bologna saphenous veins, 8% of his population had Bologna saphenous reflux. So the distribution for the prevalence is quite broad. For the small saphenous vein, the only study I could identify showed about 1% of the patients had extension of great saphenous vein reflux from the junction or from the thigh extension down into the lower calf, with an additional, and this is true in both men and women, with some additional segmental reflux, which may or may not be important. Obviously, the reason we worry about the really low part of the great saphenous vein and the small saphenous vein is because of the proximity of the saphenous nerve and the sural nerve, respectively, to those veins. Histopathologic study, a very interesting one done on patients who had ablation immediately before amputation. So the ablation was done, the leg was amputated, and the vein was extracted along with 3 centimeters of tissue around it. 5 limbs were treated, standard 8-10 ablation. The results showed typical GSV ablation findings at the immediate post-procedure period, but no evidence of nerve injury or saphenous nerve injury or saphenous branch injury. We worry partially because of the extrapolation from stripping. And here's a study of 26 patients who were stripped conventionally as part of a study who had EMG on all limbs that were treated before and after ablation at 2 and 12 weeks. A complicated or busy slide, but if you look at that slide, about 35% of the patient had an EMG abnormality, about 25% of them had a clinical abnormality at 2 weeks, and that number dropped to about 8 to 4% for the EMG and for the clinical positivity at the end of the 12-week period. So it happens fairly frequently early, and it persists at 12 weeks in somewhere between 5 to 10% of patients. The same exact study was repeated using laser, EMG before and after laser, standard 1470 jacketed laser. They did a 2-week EMG follow-up and compared that to the patients who clinically, or at least historically, were reported as having with laser by a systematic review 5 to 10% of the time with injury. They treated 41 plus or minus 7 centimeters of length. So you might argue that maybe the lower part of the GSV wasn't treated in all of these patients, but it was in some. The average joules per centimeter, pretty typical. No EMG findings, some dysesthesias in a small number of patients in the thigh, consistent with what's reported in the literature, but beyond 8 weeks, those dysesthesias went away. Dr. Thiva Kumar looked at a randomized trial trying to study what the value of adding below-knee saphenous ablation is. And I'm not going to get into that particular part of the study, but I'm going to look at the subgroup of 21 patients that were treated with both above and below knee ablation using standard technique, entering just below the lowest varicose vein or at 70 centimeters, whichever came first. He treated between 49 and 60 centimeters, so he's definitely getting into the risky area. And when he treated in that cohort of above and below knee ablations, he had no nerve injuries. One more study, this is from the Mayo Clinic, a retrospective study, 77 with laser, 2 with closure fast, 65 that were treated with concurrent above and below knee great saphenous vein ablation, and 14 that already had an above knee great saphenous ablation and they were just treated below. about half and half with CVI and not CVI. Big distances used for the above and below knee treatments only were lower. 4% paresthesia rate, all gone by 4 weeks. Small saphenous vein data, just to quickly summarize that. 60 patients treated with small saphenous vein reflux, typical laser parameters, but the groups were divided into two, randomized, lateral malleolar access and mid-calf access, regardless of the pattern of reflux. Even if the reflux didn't go that low, that's where they ablated the veins. 30 patients in each group, 6-month follow-up. There were more paresthesias in the group where they went all the way to the ankle, but actually all of them were gone by 2 months. Again, less paresthesia. So certainly more paresthesias when you go low, but no significant profound sensory loss and no dysesthesia specifically. Another study, I think this is the final study I'm going to talk about, ultrasound determined puncture site, was based on where the sural nerve and the small saphenous vein got on ultrasound. When they got to 5 millimeters or closer, the puncture was done just above that point. Typical ablation on 30 patients. They found when, first off, the point where the vein and the nerve came together was higher than the mid-calf in 10% of patients. And Dr. Ricci had shown that a while back. It's somewhere between 10 and 31 centimeters from the knee crease, most of them being between 20 and 24 centimeters below the knee crease. Using the strategy that I described, they had no sural nerve injuries in these patients that were treated, these 30 limbs. So to summarize, in terms of the great saphenous vein data in size, 12 millimeter or bigger veins exist probably in about 10 to 28% of the patients that we need to ablate. And thermal ablation seems to be fairly successful. These aren't super well powered studies, but there aren't a lot of patients up in that tail that are getting examined. In terms of looking at the low calf great saphenous vein and the lower calf small saphenous vein, it looks like great saphenous vein reflux occurs there in a fairly broad range between 14 and 55%. But definitions differ in the literature, but it seems to be pretty low, rare in the small saphenous vein based on epidemiology. And even then, what the relevance of that reflux in the lower calf means is unclear from the literature. Certainly the risk of great saphenous vein and small saphenous vein nerve injury exists with thermal tumescent, but it seems to be pretty low looking at the data that's available, certainly much lower than surgery. And at least in the literature, they're all temporary, although we know from clinical senses that some of them don't. And maybe using the ultrasound is a way to venture into the lower part of the leg vein a little bit more carefully. My final slide, in terms of practical recommendations, combining things that I and Steve Elias talk about, treat based on the clinical situation and the anatomy. So for a C2 patient where your tolerance and your patient's tolerance for complications low, don't treat that lowest part of the GSV and SSV. Some will argue, maybe patients will have some more symptoms. There was a really nice article I'll encourage you to look at in the recent Journal of Vascular Surgery, Venous and Lymphatic Medicine, that shows the relevance of treating that below knee segment may be quite low when you look at quality of life outcomes and VCSS. With C6 disease, I think we're probably going to need to be more aggressive, and probably the recommendation should be damn the torpedoes and go to the lowest point of incompetence, particularly the more severe the ulcer is. And so thank you for your attention, and I applaud the organizers for this foundation for their cause. Thank you very much. I can't hear Sergio.
Can I?
Okay.
Sergio?
Can you hear me?
Yes, I do.
Okay,
Sergio?
so I was just congratulating you. You really gave the evidence base that you are indeed the Michelangelo of the thermal tumescent, and not only. And now we start with the scientific word round. So we'll touch the different continents with a top expert representative. And it is my deep pleasure to introduce Denis Borsuk, all the way from Russia, with his question. Denis?
Hi, everybody. So do you hear me?
Yes.
Yeah.
So with the protocol, I should ask a short question as a bullet, but I will ask you, Neil, before I want to. Notice that in your analysis, you had a lot of papers with bare fibers, but nowadays all of us using radial fibers. as well as when we are thinking about neurological complications. We are interested not in LAG, we are interested of feelings of patient, you know, so, and firstly of quality of life. And in our paper, which was published in Russia, we asked patients this question, and it was very, very low. So a lot of patients didn't suffer from, you know, of so some problems with quality of life. So my question is, do you think that investigations in thermal to method have some real scientific future? Can we really improve our results? Because in my opinion, nowadays, using radial fibers, we have fantastic results, and all of our scientific, so in my opinion, these methods reach their peak. So it's very difficult to find something better solutions and improving extremely results for patients. What do you think about it?
Yeah, thanks, Dennis, for those comments. I think two things you brought up. First off is the quality of life of the patient. And I think most of the time that there is some kind of nerve injury, the nerve injury tends to be numbness rather than dysesthesia or feeling of excessive pain or annoying pain. And I think most patients tolerate that numbness fairly well. They talk about it and then they forget about it. And in fact, most of the time when they come back a year or two later and they're talking about their other leg, they don't even talk about the problem. I have to go back and ask them about it. In terms of getting more data, I think it helps to know a little bit more about certain aspects of thermal ablation, specifically the two topics that I brought up. I think you've contributed, at least in the context of a presentation at Charing Cross, that outcomes with the radial fiber are very good with very large veins, and I would encourage you to publish that. I think that's very useful. But I think one of the challenges with the literature we have right now is that they're small series that are underpowered, and it would be nice to put these issues to bed with good studies, with modern techniques, as you're describing, with radial fibers or jacketed fibers, as we tend to use in the United States more. And I do think I agree with you that we're probably about as far as we can go with thermal ablation. But it would be nice to just prove, for instance, that it is safe, or how safe it is to do ablations in the lower portion of the calf, from the knee down, with both the great and small saphenous vein.
Thank you so much, Neil. And now we fly all the way to Latin America. Oscar, can you introduce the representative?
Let me introduce Dr. Victor Canata, Vice President of the UIP, and my colleague and my friend work together now. Victor.
Thank you, Oscar, for everything. Thank you all, Willie, for this excellent and magnificent meeting. Neil, I just would like to know something. We are talking about the real world. I saw your presentation was really nice and excellent. But when the patient comes after you do your treatment with numbness and some trouble over there, what is your recommendation for treatment? What we can give besides some kind of maybe ointment or maybe treatment just to the numbness go away faster? This is my question.
Yeah, I'm not sure there is any data to support that. And I think the only thing we can really prescribe is reassurance that most of these numbness situations will go away. That's based both on personal experience, but also on reviewing the literature that I presented. So I'm not sure I know of anything. You know, I think some people use things that are, you know, the gabapentin type class of drugs, but I know of no evidence that it makes any difference. It doesn't seem like most of these injuries are saphenous nerve injuries. They probably are branch injuries. Many of them occur in the thigh, as was pointed out in one of the studies. And I think telling them that it's going to get better on its own is probably the most important thing we can give them.
One more question too.
No, I'm sorry. During the open time, Victor.
Okay,
Victor,
during the open time. That's it.
So
Thank you very much. Excellent.
There will be 10 minutes later on for open discussion.
Excellent. Let's go.
So we go back to Victor later on. Now we fly all the way to Europe. Willie, if you can introduce the representative from there.
Yeah, it's my honor to introduce Dr. Massimo Danisi, who's a board member of the Italian Society of Clinical Experimental Phlebology.
Massimo, unmute yourself. Unmute yourself, Massimo. Khaled, unmute him, please. Okay.
Okay.
Massimo, you're on. Okay. Question.
Okay. Thanks, Sergio, for your big work. It's a very great webinar. This one, you are a very friendly, but also a very big medical doctor. Thank you.
Thank you.
I represent the Italy, but now I represent the Europe. The society I represent is the SIPS, and I thank for all the member for the SIPS from Italy. The question is very small, but it's also very important. The question is for the good relation, which occlusion percentage you have for diameters in 8 millimeters, and which occlusion in diameters then greater 12 millimeter? There is a difference, and the difference in what months at follow-up? Thanks.
Thank you. I'm going to ask, by the way, nice to meet you, Massimo. We've never met before. Sergio, could you summarize his question?
Yeah, it was asking about 8 versus 12 millimeters, if you have data and related follow-up comparing the outcomes.
Yeah, the data that I found, you know, obviously there's a lot of data in the smaller diameter range for laser, and it depends on how aggressive you look for it with ultrasound and how long out you follow it and what your definitions are. So I'm not going to comment too much on the veins below 8. Those seem to close very likely, and I think there's a lot of literature to support that. You know, certainly in the low 90s at 1 to 3 years. There's a number of randomized trials that have looked at that. What I focused on particularly was the large veins, because it was always my concern with these really big veins, particularly when you get much bigger than 15 millimeters, that they wouldn't close and that we'd probably have more thrombotic complications. The longest of those studies that I reported was 1 year. A few of them were shorter. Dr. Whiteley's was just a few weeks. And so you can argue that it's the quality of the evidence for the larger veins is not as strong as the current quality of the evidence in the randomized trials that go out 5 years for laser of smaller veins. But I think we can be pretty confident that the veins are closing almost universally at that, you know, within that 6 to 12 month period of time. The keys though are technical. You need to use more energy, I think, if you're using laser. Maybe if you're using radio frequency and you're dealing with the really big veins, you might use more cycles. You want to Trendelenburg the patient to drain the vein. You want to use a lot of tumescent anesthetic. And I haven't tried to reposition the laser fiber and advance it up and treat, and then pull it back, pull back and then advance up again and treat the same segment a second time in a different part of a collapsed vein that collapses like an oval. But it seems like that's something others do, and I don't know how much more it adds to the ablation. So I'm not sure if I exactly answered your question, but I tried to.
Thank you so much, Neil. Perfect, and thank you, Massimo. Now it's my deep pleasure to fly all the way to Asia, introducing Professor Dong-Hee Kim, a familiar face for many because we still remember the wonderful meeting of the UAP in 2015, a great professional as well. So Dong, your time for the question. Thank you. Dong, can you unmute yourself? Unmute yourself. Okay.
Okay,
great.
can you hear me?
Yes, perfect.
Yeah, thanks, Sergio, and thanks, Neil. I enjoyed your talk very much, and I still remember our sweet memory during 2015 Seoul UIP. Dr. Neil, I would like to comment and ask one point. In my experience, currently I also used radio frequency or endovenous laser ablation to treat this varicose vein. But before the era of endodermal ablation technique, as I'm a vascular surgeon, I did high ligation and stripping of saphenous vein. And there was some important point in in this method of conventional surgery. That is, we were educated to ligate all of the branches around the saphenofemoral junction, because the major cause of recurrence varicose vein around the upper thigh and vulva area comes from these branches of saphenofemoral junction. So in my experience, I always did ligated these branches, but after using the endodermal ablation technique, we usually ignored these branches. So I wonder, many patients will visit our clinic due to recurrence varicose vein. So Dr. Neil and maybe all of the attendants, I would like to ask your opinion about this point. Thanks, Neil.
Thank you. And I also remember very well the trip to Korea in 2015. I had a great time, and I've been back since as a result of that. I think that's a very good question, and I think what we've found with the endovenous ablation techniques is that the pattern of recurrence is different after endovenous ablation than it was after stripping. After stripping, the recurrences tended to be, or at least the most common pattern of recurrence was neovascularization at the saphenofemoral junction as you described. With endovenous techniques, that particular pattern is very uncommon. There are a number of papers looking at large studies or personal experiences. We did one ourselves, and that was a very, very unusual pattern. The most common pattern was recurrence or new reflux, I should say, in the anterior accessory saphenous vein. And so you could argue perhaps ligating that vein at the time of ligation and stripping minimized the recurrence there, but there's no evidence to say that that particular maneuver would reduce the recurrence in patients who have endovenous ablation. But yes, it's a very interesting observation in how the recurrence patterns changed, and perhaps some of the logic that was used to ligate all those veins at the saphenofemoral junction were at that time certainly dictum, but not necessarily evidence-based.
Thank you. Okay, thank you so much, Neil and Dong. We now move to the part of the open questions, and I was looking at the question and answer, and I asked Khaled to allow the mic of Dr. Shoaib Padaria, because there are like two questions, same numbers of likes, but it's Shoaib's birthday, so I think we owe him the chance of even say hi to everybody, and we collectively say happy birthday to him. Shoaib and Khaled, if you can allow the mic of the attendees, Shoaib Padaria, please. Shoaib, are you there? So while we are waiting, the question is, how do we ensure that the diameters of veins report?
Can you hear me, Sergio?
Oh, finally. Happy birthday virtually for more than 600 people.
Thank you very much. Thank you so much.
Your question.
Yeah. First of all, Dr. Neil Kilnani, lovely presentation, very concise, very to the point, and a lot of information in your talk. Now, when we study all these various or go through all these various papers from different places, how do we ensure that the size of veins which are mentioned in different papers is more or less comparable? Are we making sure that the position of the patient is really in an upright position for a period of time before the vein dilates? And is everybody actually following the same protocol for sizing the veins? Because I think that will be a very important point in deciding whether the results, final results of different series are comparable or not. That's my main question.
I think that's a very good question, and it gets to the point that reporting standards, the more uniform they are, the easier it is for us to interpret literature. Most of the folks that wrote those papers were measuring the great saphenous vein just below the saphenofemoral junction. Some provided more detail, some provided less. Some said that they weren't measuring the largest bulge. As we all know, sometimes there's a very focal bulge of the great saphenous vein just below the junction, and then it tapers very quickly down to a different diameter. Some chose not to measure that. Others didn't report what they did. The French Society of Phlebology reported, when I showed you the distributions of the diameters, reported measurements at the mid-thigh level. I believe it's Erika Mendoza from Germany had written a paper a few years back in the European Journal of Vascular Surgery looking at the differences between the mid-thigh and the high thigh, and there was a clear difference, getting to your point. And she was able to develop a conversion factor based on a large number of patients that she studied. And so and in that paper, which was the only one that I described to you where they didn't measure the great saphenous vein at the saphenothermal junction, did a conversion. And so the roughly 8 millimeter mid-thigh vein became 14 millimeters at the junction, or just below the junction. So yes, I think that's a question that comes up with lots of things. We could think a little bit more broadly about your question with laser, and a little bit less so, but still maybe increasingly so with radio frequency ablation. These are heterogeneous techniques. Different laser fibers, different laser energies, different joules per centimeter, different watts, different amounts of tumescent anesthetics with laser, and with RF. Right now, different numbers of cycles that are run, and now new RF catheters coming out. So we have to be really careful when we read this literature to make the comparison. So I applaud that question. Thank you very much for it. And congratulations on your birthday and happy Father's Day to everybody out there. We'll notably call out Dr. Giannassini missing or not having a happy Father's Day. His mom wanted me to point that out.
Let me work on that. I'm still so young.
You're
but
here, so don't worry.
Sure. So we go back now to the second question that is from Andrei Shevov, and the question is about, again, what traction speed and laser power do you use in case of large GSV, extrafascial segments, and the distal part of the GSV? Because this is quite an interesting question, I think, Neil, because it was published by Van der Bos and also by Mascarat, I think, recently, two contradicting papers about the importance of power versus pullback. So can you just rapidly sum up your vision about pullback and power? What do you consider like the most important parameters to focus on, if any?
Yeah, I think that's a good question. I think when your power is high, it's sort of like if you're grilling a piece of meat. When you turn your power on really high, you deliver all the joules, but you probably don't penetrate the tissue as much. When you reduce your power level and try to deliver the equivalent amount of energy, you probably cook a little bit more thoroughly through, but maybe even beyond where you want. I can only answer anecdotally. I will actually even reference Dennis Borsuk's paper where he looked at this particular issue. And maybe I'll turn the mic over to him, but summarize my understanding of his work is that he looked at a controlled amount of joules per centimeter at different power levels. And he ended up with equivalent outcomes in terms of closure and patient-reported side effects. And Dennis, would it be fair to ask Dennis to complete that response?
Just very quick answer, Dennis, please.
Yes, so we measured, so we had 3 groups with the same lead but different power setting, okay? With different pullback traction, we had so different damage of venous walls, but then we compare them clinically, and we didn't have any difference between both of these settings. So that was our main idea of the study,
yeah, I think it's really interesting because, again, you have contradicting literature on this topic. If you look at a Mascat paper, it's different from what Van der Bos was reporting, and then you have also Dennis data. So I think it's food for thought for future investigation for sure. Victor, I would welcome your last question, Victor, since we cut you out before. So do you want briefly to give us your question to Neil, and then we move to Thomas?
The idea is like this: when we have those kind of new machine of duplex sono, you will be able just to separate the vein when we are do the puncture over the duplex sono, trying to see if we move just a little bit further, not to make the puncture also of the nerve when we're doing that. Do you think that will be improved the way that we are doing the approach of the saphenous vein, and we'll be able just to go down just a little bit with the numbness that we have?
Yeah, I think that's a good question. I think some of the numbness isn't a thermal injury, but rather just an axis injury, with the needle. Now, that being said, if you look at the studies, if they're accurately reporting their outcomes, which use non-thermal ablation, you don't hear about any paresthesias in those studies. Now, they may just choose not to carefully ask or carefully examine their patients because they're assuming that it doesn't happen. I do think it probably happens occasionally. But it doesn't seem to be that common looking at least the non-thermal literature.
So thank you so much, Neil. Again, a virtual applause for the wonderful performance. And we welcome your expertise also in the next section of the webinar. Now we are passing the baton from Michelangelo to something, let's say, different in terms of techniques. Let's see the results of that. Indeed, it's my pleasure to welcome Professor Urbanek Thomas. It's like introducing Salvatore Dali if Michelangelo was Neil. Professor Urbanek is one of the heads of Silesia University in Poland. He's one of our best representatives from Europe, and all the ones who have attending his meetings, including also the last from the UAP, knows what a wonderful host he is. So Thomas, the mic is now to you to enjoy your lecture about the thermal, non-thermal, non-tumescent. So latest data and evidence-based news.
Thank you very much, Sergio. It's an honor to be the part of this project, and after Neil talk about the thermal methods, I would like to share some information regarding non-thermal or tumescent methods. We have, of course, several expectations of the patients regarding the varicose veins treatment, like the method with no pain, low recurrence rate, safe, fast, ambulatory with good cosmetic results, fast recovery. But there is the question, do we have such a treatment method? And already now some comments regarding this. We cannot fulfill all expectations in many countries. For most of them, the patient needs to pay. Economical factors are important, and the treatment should be provided by someone with knowledge and experience. But of course, the patient should be informed about the alternative. And also there are some physician expectations to find the ideal method which would be good for everything. So what about NT methods? I will not focus on sclerotherapy because next week we will have the webinar dedicated to sclerotherapy. So 3 other methods will be discussed. And if we look into the arguments that are used when we speak about the use of NT methods, of course, this is one of the alternatives to the thermal tumescent with low pain complaints, no tumescent anesthesia, so low risk of nerve injury, fast procedure, fast recovery. You can use this in many locations, including below the knee, for MOCA, also for extrafascial space. And the advantage of glue, which is emphasized, is you don't need the compression. So let's start with MOCA, but already starting, we have the big question, do we really have the standard method of mechanochemical ablation? Because it seems that not. Should we use liquid or foam? How deep should we go into the vein wall? What should we use to irritate the vein wall? Or should we dissect this wall? What should be the concentration of the agent, speed of ablation, and what to do with the big veins? We have 2 systems right now in the market. You all are familiar with, at least with Clarivein, the new device, relatively new device is Flebogrif, coming from Poland. But the concept of MOCA is not only the spasm induction and foam volume decrease or sclerosing agent decrease, but it's also the efficacy increase due to fibrosis increased by the better drug penetration. And if we look into the Clarivein mechanism of activity of working, which is rotational irritation of the vein wall, it's according to the pathological studies endothelial, in some studies also intimal layer injury, which gives the possibility to get the better penetration of the drug into the vein lumen. And this was confirmed, for example, in this study. This is Mark Whitley study. If you put the piece of vein into 3% STS for 10 minutes, the penetration of the drug is up to 300 micrometers. But if you do the MOCA before, I mean, when having this inside the sclerosing agent, the penetration is significantly deeper. If you look into another device, Flebogrif, the mechanism is different. It's a pullback technique with cutting the internal part of the vein wall. So cutting the intima and also in some of the specimens, media of the treated vein. So what are the technical advantages of MOCA? For sure, it's alternative to thermal tumescent in many patients, but for sure you can use this also for below the knee treatment. You can use this for extrafacial treatment. And as you don't use the tumescent anesthesia, you can use this also in the regions where you have the induration of the skin, like C5, C6 patients with a very good visibility of the catheter. And because of shape of the catheter and possibility to maneuver with the tip of the device, you can use also this device for some tortuous vein pathology. Phlebogryph is over the wire system, so the wire can be used. Some reports confirm, I mean, many reports confirm that both these methods are relatively safe. However, some typical for mechanical methods complications are also described. And when having the rotational mechanism or when having the pullback incision of the vein wall, you can stack to the vein wall. And there is one case of retrograde inversion stripping described in the UK when using Clarivane device. What about the results? The early results, of course, are perfect. In early results analysis, you will find very high occlusion rate, but unfortunately in the midterm results, the occlusion rate is going down, and we still do not have a good study regarding longer term follow-up. Just few studies with 3 years observation, it's 87% occlusion rate on the small group of the patient. This is the study from Italy presented in EVF Porto with 3 years occlusion rate 89%. What about the new study? Because the learning curve probably matters. And as we can see in these two studies, Maradona and Lama recently published, the midterm results do not look very satisfactory. It's anatomical success means occlusion rate at 1 year 83% and at 2 years 80% for MOCA. In Lama trial, even lower, 1 year 77% occlusion rate. What about the phlebogryph? Do we have any data? We have some of them, but we are waiting for more. The first study was done by inventor of the system, Peter Ciostek from Poland, with 12-month occlusion rate 89%. Up till now, the biggest study comes from Lublin in Poland, the group of Zubilewicz and co-workers, with 12 months occlusion rate 92% and 24 months occlusion rate 92%. Some new studies are coming. This study was presented at UAP Krakow, and the study coming from Russia and Belarus. 175 patients and 92% occlusion at 12 months of the follow-up. And right now we are waiting for the new study. This is the ongoing study in Poland, multi-center prospective study in 4 centers with 200 patients, which will be recruited on safety and efficacy of phlebogryph. So probably the biggest study that was conducted is right now ongoing. So in summary, regarding mechanochemical ablation, for some indication it's essential. For example, below the knee or very superficial veins. In some other indications, comfortable, good, early and satisfactory, but of course not in all studies midterm results. Probably the late results are not as perfect. Low complication rate, not for large veins. It seems to be not a good method for very large veins. And this is, of course, not the technique that we use, that we should use to close the stump and to the ostium of the saphenous vein. Regarding the second method, which is NT as well, cyanoacrylate adhesive ablation, we have different systems, but we have also different types of the glue, of the cyanoacrylate, with the variety of the polymerization time, as well as different viscosities. But the results in comparison to MOCA seems to be much better. The early and also midterm results from 12 to 36 months looks very satisfactory, having in mind the previously presented MOCA results. This is the systemic review of more than 100 cases with 12 months, 96% occlusion rate and 30 months, 94%, which looks very, very satisfactory. And now we have also the long-term results. You remember the VCLOSE trial, which was up in the observation up till 36 months with cyanoacrylate occlusion rate of the vein 94%. And in the VCLOSE 5-year follow-up extension study, 89 patients were examined, with 47 patients treated by cyanoacrylate, and complete closure was observed in 91% of the patients treated with cyanoacrylate. There is one more important message: no granuloma or other late allergic reaction was documented in this patient group. But there are some questions regarding the glue that we discuss in many of the congresses and events. There are some contraindications, and the important question: can we use glue for each patient? Because probably for very superficial located veins or extrafascial location, and also for large saphenofemoral junction, will be difficult to apply this technique. And for sure, we should follow the instruction for use and also follow the glue, because we start vena seal 5 centimeters from the femoral vein, and the Turkish glue starts usually 3 centimeters from the femoral vein. And even having such a distance from the osteo, remember, you can cause the migration of the glues if you don't follow this properly. And if you want to switch non-stamp technique, which is cyanoacrylate adhesive, into the stamp occlusion technique, you can have these results. And these are the glue. And this is the glue in the femoral vein, which was extracted or pressed from the ostium, and that's why it's very important to be aware that this complication had happened. What about the small saphenous accessory or perforating veins treated by cyanoacrylate? From Kathleen Gibson and WAVE study, we know that we can treat small saphenous. We can treat accessory saphenous vein with the good at least 3 months results. However, this patient should be followed, and we should probably have more data about this, because if you look into 2019 study on small saphenous vein, at 6 months occlusion rate 71% and 12 months 62, for sure is not satisfactory to anyone who is using this method. Perforating veins, can we treat them? For sure, yes. Kathleen Gibson and Kursat are with us. So they have much more to say about this, because they do this procedure as far as I know. And there is the study published 2014 with 33 incompetent perforating veins and 76% elimination of reflux. But remember, not all devices and glue are registered for tributary and perforators. That's why this probably not can be done with all stuff that we have. One more issue regarding the glue is so-called phlebitis. So we speak right now about hypersensitivity and allergic reaction. We know that frequency of this complication or sequelae of the procedure is from 3 to 20%. In most of the cases, this resolves spontaneously and does not occur immediately after the procedure, but in some days after. We know that the quite big number of patients and quite big percentage of population will have the cyanoacrylate allergic reaction or hypersensitivity. We can count on the 5% of the general population regarding this. So previous exposure to the cyanoacrylate matters, even if we are not exposed to the particular cyanoacrylate. The cross action between the cyanoacrylates happens. Kathleen Gibson show in the study based on almost 300 patients that cyanoacrylate hypersensitivity happens in 6% of the patients. In most of the cases, it's mild or moderate, which resolve spontaneously. What about delayed glue complication? We have some reports, but very few of them, and this is very, very rarely reported. Complication, we know that more than 100,000 cases of cyanoacrylate ablation was performed, probably much more. And at least for now, it should be not taken as a group effect, as a cyanoacrylate ablation, and probably can happen. So we should follow the patient. The patient should be also aware about this, and we should always count and evaluate the concomitant diseases presence, as well as the possibility of the allergic reaction, hypersensitivity to cyanoacrylate. So this is general concerns for 2020 regarding the cyanoacrylate. Hypersensitivity exists. We should properly qualify the patient, and if required, we should exclude the patient. Post-procedure follow-up is obligatory. Most of the hypersensitivity cases are in the early postoperative period. And of course, not all patients has to be treated by glue. However, very, very few cases of granuloma are reported, and as I mentioned, it shouldn't be not treated as a group effect, I mean granuloma formation. To summarize the glue, it's for sure alternative methods for thermal tumescence, useful for classic indication, but also for some anatomical locations like below the knee or small saphenous. Late results expected, not for extrafascial saphenous vein, probably not for large vein as well. New indications coming, perforating veins accessory. It's also not a non-stamp technique, often in many countries still expensive. The last method on the list, almost last methods regarding NTNT is V-block occlusion system based on self-expandable vein occluder and sclerosafe, which is a dual syringe system. And this is one of the biggest study, 51 patients with 98% occlusion rate at 7 days and 77% at 3 years. This study was published 2019, so more studies are needed regarding this. And we have Chris Rack with us, so I put also this still experimental, I think, method, but seems to be promising. Hyaluronian valvuloplasty, so perivenous hyaluronian injection to restore the valve competence. So Chris, we are waiting for more results, as probably this should be also followed for a longer time. What's the role of NTNT in current recommendation? There are the recent recommendation from Phlebology 2020, European College of Phlebology guideline for truncal ablation for both methods, cyanoacrylate and MOCA, to be class of recommendation. And this is the latest recommendation coming from International Angiology document published by the group of Professor Nicolaides, guidelines according to scientific evidence. And as you can see, there are the recommendations, same recommendation from cyanoacrylate and MOCA in the armamentario of the methods that we can use for this saphenous vein treatment. So probably more studies are needed to get more data to get the high rate of recommendation. So is still answering this what we saw in the previous lecture, is thermal ablation still standard of care of the truncal varicose veins? In my opinion, probably not. Best option for now is tailored treatment, means a la carte treatment proposal. Not all truncal varicose veins can and should be treated in the same way. Probably in our offices, we should have the access to thermal, but also at least one non-thermal method. And as was asked in the beginning, none of the currently used method fits all expectations and requirements. Thank you very much, and thank you once again for having me on board for this wonderful project. Thank you.
Thank you so much, Professor Urbanek. Indeed, like Salvador Dali, a real artist. I ask Khaled to allow my share screening, please, so that we can move forward with the scientific round. And here we are. So it's my deep pleasure to welcome from Turkey, Professor Kursat Bozkurt, and it's a great chance also to remind you to put in your agenda the UAP 2021 meeting. So Kursat, are you ready for your question?
Hello there. Thanks a lot, Sergio.
Yes.
I am ready. I'm ready. Thanks for the wonderful organization. Thomas, just one quick and simple question. When we are doing NT, doesn't matter glue, doesn't matter MOCA, we are leaving a long stump, long segment, definitely longer than laser treatment. Do you think that may increase in future the recurrence from anterior accessory saphenous vein?
For now, for sure, for both these methods, I mean glue and MOCA, the risk of leaving stump is very, very high. And this method are promoted and should be promoted as non-stump occlusion technique. And I think that if we have the doubts about leaving the stump, probably the best would be to choose another method, because with laser, you can do the laser fluoroscopy. You can try to do this also with radiofrequency. But regarding this, I would not consider to advise glue for the stump occlusion. It can happen accidentally, and so we see this in the praxis, but this should be not done intentionally. I showed the pictures of the procedure that finished with the glue migration. That's why I think if we have doubts regarding the recurrence, we should probably switch to another armamentario of the methods.
Thank you so much. And now we move on the way to Africa. We are literally on the road, as we heard from the sound in the background. So Willy, can you introduce the next expert from Egypt?
Yeah, it's my honor to introduce Professor Ayman Fakhri from who's the head of the Egyptian Venous Forum.
Ayman?
Thank you. It was my pleasure to be here with you. And thank you, Sergio, to give me for this such a great event. Dr. Urbanik, I like your talk very much. It was very nice, and indeed I got a lot. As you mentioned, thrombosis is a potential cause of recurrence, and the MOCA catheter is a little bit expensive. And as I go through the literature, no head-to-head study comparing MOCA to catheter-directed sclerotherapy. My question, do you think it is a cost-effective method using MOCA versus catheter-directed sclerotherapy in ablating great saphenous vein?
I am not aware about the randomized control study regarding this, and but we can find at least some of the advantages regarding MOCA, especially regarding the volume of the drug that you use, because this is what you do, and using MOCA is shrinking the vein. Of course, the penetration is also important, but if we take into account the amount of foam, for example, that we can give during one procedure, if you not shrink the vein, which is 1 centimeter in size, then you will need some syringes of the foam that you need to give to the patient. When you shrink the vein to the 1 or 2 millimeters, 5 cc of foam will be enough to close the entire length of the saphenous vein. But you are right, in some of the patients after Clarivane and also after phlebogryph, we see something inside that can be the thrombus, and probably this is the source of recanalization afterwards, but I am not aware about any study that is comparing MOCA in randomized controlled trial with the catheter-directed thrombolysis. If we take the issue of money, for sure, this is the important concerns that we should have in the mind, that the cost of the catheter, just a simple angiographic catheter, and cost of MOCA will differ. So I think that we have to adjust this also to economical condition in the countries. As far as I know, in some countries, there is reimbursement for MOCA. In Poland, we do not do this with the medical insurance. The patient has to pay for everything. So only some patients choose this.
Thank you so much, Professor Urbanek. And now we fly all the way to Latin America, thanks to Willy, who is introducing again the representative.
Yeah, next we have Dr. Alvaro Orrego who's the head of the Chilean Foundation of Phlebology, Phlebial Lymphology. Dr. Orrego.
Okay. Hello.
Hello.
Yes.
Thank you. Hello, Thomas. Thank you very much for your lecture. It was terrific. Thank you again. Well, I have a question. What do you think are the most important points to consider for the future development of the new non-invasive superficial venous disease techniques?
Non-invasive? What do you mean exactly?
For example, TT, non-T, NT, not surgical. Because we are living, I think, a fashion problem with these technologies, because there are more and more techniques with lesser or same results with a higher cost in comparison with laser or radio frequency. And well, I think we need to focus what points are the most important to consider in order to find a very good technique.
Thank you, Alvaro. I think that you touched many points, because in my opinion, using only one method in the varicose veins treatment, like truncal varicose veins treatment, probably is not sufficient. We have the variety of the patients, variety of pathology, anatomy, and whatever we meet. Each case is another case, and each patient is another patient. So I think that probably we should not try to find the best method and the only method that we will use. As I summarize in the end of my talk, we should have access to different methods and to adjust them properly. But of course, you should choose this what will be convenient for you regarding the efficacy. And there is the difference between thermal and non-thermal methods regarding, for example, MOCA and laser and radio frequency. And second, you should look into the economy, reimbursement, and the possibility. That's why in some countries, probably like US, MOCA will be quite often used with reimbursement possibilities, also in some European countries. But in many countries, the catheter-directed sclerotherapy, ultrasound-guided sclerotherapy will be also a good choice. That's why I think that economy, efficacy, and also the experience of the phlebologist, and finally, the patient pathology are important.
Thank you so much, Thomas. It's my pleasure to fly back to Europe with Chris Rag. We know him as the phlebology from the future for his innovative ideas, as also Thomas reported. So Chris, can you make your question? Chris, unmute yourself.
Yes.
Okay.
Thank you for giving me 1 minute to change the world. Thomas, thank you for this excellent talk. To set the basis for my question concerning MOCA, you mentioned additional effects, application in interfacial veins, in tortuous veins. I think we have no proof of advantage versus a good foam sclerotherapy, and to my knowledge, there's no study on that so far, and not even a comparison to the novel biomatrix sclerofoam. Second, the glue, it's too aggressive, it's not biodegradable. I missed a note on future solutions like the novel scleroglue method or novel bioglues. V-block is includes a permanent implant, which we seriously don't have on our wishing list. Maybe it could be useful to think on a reversible umbrella. And finally, on the hyaluronan, thanks for mentioning this. This includes two methods. The first is just applicable in early stages. It competes stockings. It does not compete ablation. And the second variant is replacing tumor sense for a zero pain recovery period and no discoloration. So just to put this clear. My question is, which of these methods do you really favor for the future? Or do you think we should put more efforts on prevention than in doing more specifications on improvements of ablation?
Thank you for this, I think, 15 comments and the question. I see that you really wanted to change the world within 1 minute, and several points were touched. Of course, regarding the angulated tortuous veins, I don't want to encourage everyone to use Clarivein or Phlebogriff for such a veins, but in some situation happens that we are not able to go through with the straight prop. So this is an option, and this is also the answer that probably for now we cannot indicate that any of this method is the best one, because we know that results of the glue are much better than MOCA, especially mid-term and probably the long-term results as well. But we leave the permanent implant. If you, Chris, create the cyanoacrylate which will disappear, or any other sort of the glue which can work in this way, this will be probably the method that will encourage people to use. But I think that for now we need all these methods, yes. Because not all people can afford for glue treatment. Not all people can be treated with glue, for example. In some patients, you want to close the bigger veins. And I would not withdraw from sclerotherapy. It's still very good choice for many patients. That's why, as already mentioned during this discussion, we should adjust this what you have to patient's economy and to efficacy. And sometimes probably the patient will pay less money for the method that gives lower efficacy. And this should be also taken, because if you do the procedure for 200 euro or 150 euro regarding the stuff that you use, and this is the total cost for the patient, this can be very interesting for many people. Of course, you can do the same with the stuff which will cost 1,000 or 1,500 euro. So many conditions have to be taken into consideration.
Thank you so much, Thomas and Chris. Thomas, we now welcome the open question phase, and the one was received most likely is the one from the Cleopatra of phlebology, so Wasila Taha. And she is asking, is there any difference between STS and polydocanol and use concentrations in terms of pigmentation, especially when used in superficially located trunks, extrafacial?
But we mean about MoCA, yes?
Yes.
In both these methods, I mean, there is no head-to-head comparison regarding this. And in both these methods, with Clarivane, which often use STS, and also phleboglyph, where in reality we use only polydocanol, hyperpigmentation happens. So for all veins which are superficial in extrafacial space, we can expect the hyperpigmentation, and I'm not aware about any head-to-head comparison if we treat large vein located very, very superficial.
Okay.
So both can be expected.
We will welcome further open questions later on if time allows. I'd like now to focus on the honorary chairs, and we have the huge pleasure of having with us Kathy Gibson, who is one of the biggest experts in the field. So if we can give the mic to Kathy for first wrapping up of ideas, and then we will welcome further open questions. Kathy?
All right, thank you very much. And I really appreciate the opportunity to view these presentations ahead of time to make some prepared remarks. And also thank you, Sergio, for inviting me, and welcome everyone. And I appreciate it. So I think the two presentations were excellent. We are indeed fortunate to have so many tools at our disposal to treat patients with venous disease. We are also fortunate to have, actually, hang on a second. I'm gonna go off of share screen because I was reading my notes. Oh,
sorry, my fault.
That's all right.
I just want your introduction.
That's all right.
Properly, sorry.
I had notes in front of me and then they went away.
No, everybody knows you in the world, so, but I just wanted to give a picture.
Yeah. So you might have thought that I was doing this all from memory, but I'm actually reading something. Okay, so we are fortunate to have well-established technologies with long track records in endothermal ablation, as well as newer technologies in which some of the circumstances may offer our patients a different experience. The acceptance of any new technology in clinical practice depends on the fact that it needs to have comparable efficacy and needs to have some perceived benefit over what came before. Otherwise, there's no need to have this new technology. And we need to balance this against any unique or shared risks. For example, a shared risk would be something like DVT or infection that can occur with any device or procedure. Unique risks, like what we see with cyanoacrylate, would include hypersensitivity or the very rare circumstance of granuloma. This must be balanced. Additionally, we need to consider costs, and these will vary by country and region. These costs must not only include the cost of the procedure and the components, but the impact on the patient in terms of time off work, how many procedures they need to have done, and time to get back to normal activity, as well as the cost of any complication. Dr. Kilnani showed us evidence in regards to the use of thermal techniques in veins with large diameters, and he appears to show us that with proper technique, we can get excellent results with thermal and large diameter veins. He also discussed treatment of the great and small saphenous vein below the knee and the relationship of nerves to these vessels. He has shown that in studies that he's presented that treatment below the knee is safe if done with care and proper ultrasound imaging. I would like to caution, however, even though he shows us a very low incidence of nerve injury, painful nerve injuries do occur, and patients with this complication are usually very unhappy. The papers that he showed us were likely produced by experts in the field, and their rates are probably lower than what we see in the real world. And I would like to emphasize that proper technique is important in visualizing nerves. Another possibility for treating below the knee with thermal is to treat just the above knee segment with thermal and then use foam below the knee. This is also an excellent technique when the skin below the knee is damaged. Dr. Urbanik showed us a very good review of NTNT technologies available. He pointed out that the economics must come into play. I think this is very important. And in many regions, patients must self-pay for these procedures. The MoCA has some advantage below the knee in veins above the fascia, and I agree that it can be used to steer through tortuous veins. It is very comfortable for most patients. They'll occasionally have pain if the device gets stuck in a valve. He does also review that the anatomic success rates appear to be a little bit lower than our endothermal techniques. He presented data on cyanoacrylate, and the closure rates are excellent, but the main concern is the unique complications of hypersensitivity and granuloma. So in our own clinical experience, more recently in the past 2 years, our hypersensitivity rates have dropped to about 2 to 3%, and we would attribute this drop to some changes in technique where we're very careful not to allow any cyanoacrylate to be left in the subcutaneous tissue, as well as careful patient selection as brought up by Dr. Urbanek. We are fortunate that we have never seen a granuloma, and I think we do need to have more study of this rare complication to figure out why it occurs, because I think it is unique. The talk did not touch on foam, which is widely used throughout the world and is excellent for tortuous veins. It does have somewhat lower anatomic closure rate that can be readily repeated and it's inexpensive. It is a key to tailor the technique to the patient. There can be specific advantages in non-thermals in the elderly, in the fragile, in patients who are difficult to position with arthritis and maybe less able to get in a position that you want for tumescent or on blood thinners. So I think that in the place of these new technologies in our armamentarium, more data is needed, more head-to-head data is going to come. We are curious by nature. And with so many all over the world using these new techniques and inventing new ones, we will continue to learn and develop other techniques. And I am confident about our future going forward.
Thank you so much, Kathy. Indeed, you totally deserve the honorary chair, as Professor Lowell Kamnick is, of course, another guru of the area. I'd like just to remind everyone before passing the mic to Lowell that you can make your question in the question and answer box in whatever language, and they will be all answered by this week. Lowell, the mic is to you.
Thank you, Sergio. I would like to thank VWIN for the wonderful insight into humanity and my esteemed colleagues for donating their time to this cause through education. Congratulations to both Dr. Khilnani, Professor Urbanek. Both presentations were excellent, well-balanced, presenting the current landscape of ablative techniques. With regard to thermal ablation, Dr. Khilnani reviewed thermal ablation from devices to outcomes. He addressed issues regarding thermal ablation, citing the literature and using statistical information. He concluded there are many factors involved in deciding on ablative techniques. One, there is evidence that thermal ablation is successful for large diameter veins, which represent about 15 to 28% of all veins. Two, infrequent low GSV, SSV treatment needed with C2 disease can be performed. However, we should consider the lowest point of reflux, which is probably more frequent in C5 and C6 disease. Three, risk of GSV and SSV nerve injury exists with thermal ablation. However, it seems to be low. Proper ultrasound can demonstrate risk points and reduce the incidence. With regard to non-thermal ablation, Professor Urbanek started off his presentation with often used arguments against thermal ablation. He then reviewed the device's efficacy outcomes and complications. He concluded that thermal ablation is probably not the standard of care for truncal varicose veins. In addition, he stated that not all truncal veins should be treated in the same way. Two, the venous interventionalist should have at least one thermal and non-thermal device. Finally, Professor Urbanek concluded that none of the currently used methods fits all expectations and requirements. Congratulations to both Dr. Khilnani and Professor Urbanek. In conclusion, I leave you with a rhetorical question and statement. Should the standard of care be device-related or patient-centric? And lastly, we should be looking at quality gains, which consider the cost of doing the procedure. Thank you very much for the opportunity, Sergio, and congratulations to the speakers.
Thank you so much, Lowell, for demonstrating once again your scientific quality. It's my pleasure now to move on the way to Latin America for a person who needs no introduction. Professor Angelo Scuderi has been the leading figure of the UAP, and he has been so nice to join us today as honorary chair for his remarks as well. So, Angelo, can you tell us your point of view?
Dear Ho, dear Sergio, thank you very much for the opportunity to take part of this great discussion. It was a great pleasure. I am very happy because I am seeing the phlebology for more than 40 years. And I have the opportunity to see a great evolution of phlebology. We have indeed, in the last 20 years, a great revolution with many methods to treat this important disease, varicose syndrome. And today we have opportunity to review a lot of these techniques. I'd like to congratulate both speakers. Very nice presentation. However, I'd like to make just one small observation. No one spoke about the hemodynamic issues. We talk about the size of the veins, but we don't talk about the hemodynamic. I think this is a very important topic to listen, to think. Because sometimes we have one vein that could be bigger, but it's not sick. And we need to think in this case. I also like very much the question of Dr. Kim from Seoul. He remembered one thing very important about the branches, but I don't think our branches are tributaries. It's a very important topic to think when we treat the saphenous, the varicose syndrome. Well, I am very happy to join with us. I think I learned a lot of things. Dr. Urbanek, thank you very much. Your presentation was fantastic. I liked very much. Also, the Dr. Kalan, the very nice presentation. Sergio, you are great. You make a very important meeting. I am proud to be your friend. And thank you very much for all comments, all speakers, all attendants from Italy, from everywhere, from all the world. I am very happy to be president. I was president of this important association. That's it. I'm proud.
Okay, thank you so much, Angelo, for the honor of having you here. I want to just point out that I'm just one of the players. It's a huge teamwork that starts with Oscar and Willie and all the colleagues who have worked and volunteered for this project, so thank you all. And you actually stole my comment, because indeed, you know that I'm passionate about hemodynamics, and they wanted to quote a nice editorial of 2015 showing that indeed we are getting the risk of looking at a perfect storm of unuseful data in this evaluation of the different techniques if we don't make a homogeneous comparison of the hemodynamics. With our group, for example, we published an odds ratio of 4.8 if you have an incompetence above the terminal valve in having recurrences. So I think you really touch a fundamental point, Angela. So as I was saying, it's always a teamwork. So I'd like to conclude with Willie and Oscar. Oscar unfortunately had to leave, so thank you so much, Angelo, for taking his place. And Willie, would you like to make some final remarks, please?
Yeah, thank you. Well, dear friends and colleagues, today we heard two great lectures from Dr. Kalani and my good friend, Dr. Urbanek. I think that the bottom line message is that our patients deserve tailored therapy. Just like what Kathy and Lo and Dr. Scorduri had focused on. We need to use the right treatment or method to treat the right patient at the right time. And with that, I want to thank everybody again. Doesn't matter where you are. Good morning, good mid-afternoon, and good night.
So thank you so much again, Willie. And I'd like to take this chance to invite you to next Sunday webinar. Who knows me knows that I like to stay out of the comfort zone and fish for troubles. So I will be talking about coagulation, COVID time for sclerotherapy. And I have the pleasure of sharing that Sunday with Andrew Bradbury, who needs no introduction, and honorary chairs who needs no introduction, as well as all the faculty. Once again, I'd like to deeply thank all the ones who have made this initiative possible, the faculty, individual donors, and the industry supporters, and all the attendees. I'd like to remind all the attendees that all your questions will be answered. It's not possible in 90 minutes to answer to the more than 1,500 people we are recording now in Facebook Live and also on Zoom. So I'm sure, knowing the niceness of the two keynote speakers, that they will get back to you with answers that you can find in the Big Wind Foundation website during the week. And once again, I'd like to deeply thank all the faculty of today. Really, they represent stellar professionals and friends for all of us, and I look forward for seeing all of you next Sunday. It's 5:30 over here in Italy. I wish you all a nice Sunday and a nice week, and thanks again for being part of this initiative. Bye.
Goodbye. Thank you, everybody.
And deeply thanks to Dongi Kim, who has been with us until midnight and over. So thanks for the commitment, for real. Thank you, Dong. Bye-bye.
Bye-bye.
Bye.
Angelo, bye.
Bye, 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 bye.
Bye-bye.
It was a pleasure to meet you.